Welcome. Thanks for the big crowd. I guess it's great you're all here. It's not a great sign that there's this many people with knee problems, but that's the way it is. My name is Jim Rutnick. This is Dr. Maggie Curtis and my son Ken, who works at our clinic. And this is John Gamble. You'll meet him a little bit more. You'll meet his knee later. And we have a clinic in Needham. I've been a physical therapist for 23 years. Maggie for about 4 or 5 years. So we're going to talk about some alternatives or ways of avoiding knee surgery, or at a minimum trying to prevent knee surgery. And the thing that I like to think about is the knee as a victim. We put a lot of focus on the knee itself, and doctors will do x-rays and they'll do MRIs and they'll do a lot of things to look at the knee, but the knee is really sitting between the hip and the foot, and it's kind of stuck there, and it's dependent, or it's affected by what happens above and below it. So that'll be a big part of our theme, is what can we do above and below to take some stress off of the knee. The other thing is that a lot of people, in fact, probably everybody in this room except for my son, if you were to do an MRI, and maybe Maggie, because they're younger, if you do an MRI or an x-ray on our knees, you'd probably find problems in both of our knees. And I don't have any knee pain. And many of you probably have one good knee and one bad knee, and that good knee would probably show up with problems on the x-ray and MRI as well. So what the results of the x-ray and the MRI don't necessarily predict pain. We help people get rid of pain all the time, and their x-ray and MRI would look the same. So the key is to take stress off of it, to allow it to calm down, to allow it to work in the way it was designed for. So what I say to people is, we don't have problems, we have opportunities. So think of every problem as an opportunity. But also every opportunity can lead to a problem. So it's something to keep in mind as well. So these are a little bit small. I'll read it to you. So back in the early 2000s, they did arthroscopic knee surgery they did a study to find that arthroscopic knee surgery was no better than fake surgery, both for arthritis and for meniscal tears. Those studies are usually done in Scandinavia. They're usually not done in the United States, but they literally had 200 people with meniscal tear and knee pain. Half of them got knee surgery, half of them, they put them under anesthesia, they made incisions, they woke them up, and then they checked them a week later, and both groups did equally well. So there's a placebo aspect to surgery as well as medication. And this is the same study, that surgery for torn meniscus in the knee is often unnecessary, ineffective, and misdirected. And this comes from MD Alert, a doctor. So surgical meniscal repair was not superior to sham surgery, which is fake surgery, in a randomized controlled trial. Also, problems can develop from knee replacements. So also I want to emphasize that knee replacements can be great things. If somebody really needs one, get one, because it can change your life. I don't want to talk anybody out of a knee replacement who really needs it. But I just think that we should make sure that we really need it before doing it, because it is a big commitment. It's very uncomfortable and you'll be with somebody like me or Maggie who will bend your knee, and if anybody's had it, you know how sore it is and how unpleasant it is. But a lot of people do really well with it. So again, I don't want to talk anybody out of it, I just want to make sure that it's really necessary before somebody does it. So some of the complications are wound healing problems, infection, blood clot, nerve damage, restricted motion, or pain. And the numbers tend to be like 5 or 10% have these kind of problems. So it's a small minority. But for those people who have them, it's 100% for them. So again, if somebody needs a knee replacement, definitely do it. So this one is from Journal of Arthritis and Rheumatology, and they found that approximately 1/3 of total knee replacements were judged to be inappropriate. So that's when you want to really make sure it's necessary. And these are doctors, MDs.
A question over here.
Sure.
Are you going to get into how to determine if that's true or not in your case?
I think what I would say is try something else first. Try like PT first, and if you're able to avoid it, you're able to avoid it. If your function is good enough that you're happy with it after doing PT, then you're able to avoid it. If you're still having problems, you'll have a better surgery having done PT first to get stronger, to get better ankle mobility, better knee mobility, better endurance, things like that. But we'll talk. I can address it more in questions later. So total knee replacement versus PT. They did a study where they had 3 groups: people that got replacements, people that just did PT, and then people who didn't have any therapy or replacement. What they found was total knee replacement had twice the improvement in pain and function after 2 years. So they did well. So again, I want to make that clear. I don't want to talk anybody out of a knee replacement. But the ones who only had PT, had 60% more improvement than no treatment. So PT helped a lot. And 2 out of 3 of the people who had PT did not have surgery within the following 2 years. So 2/3 of them were able to avoid surgery, 1/3 ended up having surgery. So now we'll get back to the big main theme, which is the knee as a victim of what happens at the hip and the ankle. And it's a victim, it's dependent on hip strength and good ankle motion. So this is me demonstrating the knee coming in. So we rely on the hip strength to keep the knee lined up. If the hip isn't strong enough, the knee will tend to go towards the other knee as we bend it. They'll tend to come together, or if it's both sides, they'll tend to come together. If it's on one side, it'll tend to go towards the other. And that puts more pressure on the arch, and the arch will tend to flatten. And then the foot turns out as the arch flattens. So you basically, and here's the arch. So overpronation is the arch flattening, causes lower leg rotation. So as the arch flattens, the lower leg rotates outward. And so what happens at the knee, you have the lower leg going out, and so you have the lower leg turning out, and you have the upper leg turning in. So you end up with a lot of grinding at the knee. They're going in different directions. And when they go, I can demonstrate here, and John will be demonstrating this too, but if they go in the same direction, then you can do this all day long. But if it's turning out and this one's coming in, it's putting abnormal stress, and that will irritate the knee and eventually wear out the knee. So we also need motion at the ankle in order to advance over our foot. So if we think of like this being 90 degrees, so we need to be able to go beyond 90 degrees without the arch flattening, and that's the key. If the ankle is tight, then the arch is going to tend to flatten. And then it'll turn out, and the knee will come in, and that whole thing will happen. So it's really important to get good hip strength and get good ankle motion, keeping the arch up. So this didn't turn out to be a very good picture, but I tried to show, like, this is a normal arch height. I think a different color sock would have been better, or bare feet. But this is the arch flattening, and the little piece of tape shows where the bone and the arch is. So here's that picture from before, but it shows the angle of the thigh bone, the femur, and the shin bone, the tibia. And they're going in different directions. And the arrows here, I mean, this is not perfect either at the moment because of this knee, but we want those to be more lined up. And the hip strength and the ankle flexibility will help with that. And we don't have to get these things perfect on people. I think of it like everybody's body is imperfect, and our bodies can deal with it. It doesn't cause pain. But there's a last part of it, a last, say, 10 or 20% that causes pain. So if we can get a 10 or 20% improvement, then oftentimes the pain reduces and they feel better. So there's other problems that develop from this type of motion. And I would say 90% of our leg problems that we see are coming from this pattern of motion. But other things are bunions, where the big toe is bending in, big toe is bending towards the other toes. Other problems are Achilles tendonitis, plantar fasciitis from the arch flattening, patellofemoral pain, which is the kneecap, so the front of the knee, pes and serine tendonitis, which is soreness below the knee, right in here. Hip bursitis on the side here, and piriformis syndrome, which is literally a pain in the butt. So how do we go about treating hip strength? So this is a spine, and this is the pelvis. And this would be the front, and this would be the back. And we find that people who we see, we don't know about people out in the street that don't need PT, but the people who come to our office, it's always the case that the hip strength is weaker on the side they have pain on. And we also find that the pelvis is out of alignment, that one side is rotated differently than the other. It's kind of stuck in rotation. And our brain, I think, senses that, and it weakens the muscles in that area. So we do some gentle mobilization, pushing down on the sacrum, and we use the leg muscles to loosen up that joint. And within 1 or 2 appointments, we can get that hip to be as strong as the other hip. And then that's complemented with exercises at home.
So by stretching it strengthens the...
Yeah, by getting the SI joint to move better. the strength comes back.